So welcome to this fifth webinar in the series on inflammatory bowel disease, where we'll be discussing osteoporosis in inflammatory bowel disease. And this is produced in conjunction with the Royal College of General Practitioners and Crohn's and Colitis UK. I'm Dr Ceris at Gwilym, and I work as a regional IBD clinical champion in Wales, as well as being a GP with a specialist interest in gastroenterology and inflammatory bowel disease. So we're going to start by giving a little bit of background. Osteoporosis carries a significant morbidity, causing more than 200,000 fractures per year in the UK. So as well as the pain and disability caused by the osteoporotic fractures, there's also a significant monetary cost to the health system and an associated mortality with this. With an ever-increasing ageing population, we know that we're going to see the prevalence of osteopenia and osteoporosis rising. Patients with inflammatory bowel disease are at an increased risk of both conditions, with around 35 to 40% of IBD patients suffering from osteopenia and around 15% of those with inflammatory bowel disease suffering from osteoporosis. So the relative risk for all fractures is around 1.3 for Crohn's disease and 1.2 for ulcerative colitis. Seems to be a bit greater for hip fractures, but actually the prevalence of reversible fractures is likely to be underestimated. So because of this high prevalence, it's imperative that we identify those in inflammatory bowel disease that are at risk of these conditions. So when we talk about risk factors, there's many factors that predispose to fractures, but bone mineral density is probably one of the most important, and this tends to be measured using a DEXA scan and expressed as the number of standard deviations above or below the mean. And there's various ways that we can look at risk factors, really. So we can consider risk factors as being non-modifiable, such as age, modifiable, such as physical activity and smoking. And then there's ones that I think are perhaps partially modifiable, such as the inflammatory effect in a condition such as inflammatory bowel disease, where we know that we may be able to control it to some degree, but it may still have an increased risk of reducing the BMD, bone mineral density. So some risk factors, such as increasing age and low body weight, are associated with a low bone mineral density and therefore increased fractures through that method, but also independently increased fracture risks through the patient's predisposition to falls. And we can see from studies that bone mineral density in inflammatory bowel disease is modestly reduced compared to the general population, therefore carrying an increased risk of osteopenia and osteoporosis. As I've mentioned already, when we talk about risk factors, we can think about them being related to low bone mineral density or independent of bone mineral density. And then we can also think about the risk factors in inflammatory bowel disease. And the association really is multifactorial. So we know that there's a reduced reduction in bone mineral density as patients advance in age, but also with an underlying inflammatory state and in patients using corticosteroids. So it's important to think about ways that we can prevent osteoporosis in inflammatory bowel disease. And of course, some of these methods we'd be talking about in our general consultations on patients at risk of osteoporosis. So lifestyle measures, smoking cessation, avoidance of excessive alcohol use, and taking regular weight-bearing physical activity. In addition to this, in osteoporosis and inflammatory bowel disease, we need to look at effectively managing the underlying disease, as controlling that chronic inflammation is key to improving their bone mineral density. We also really need to talk about good nutrition, in particular calcium and vitamin D. We need to, wherever possible, avoid steroids. And it's been mentioned earlier on in the management of inflammatory bowel disease and the flare pathways that wherever possible, we should be trying to avoid the use of steroids in flare management and in remission of IBD. But in particular, we should be trying to avoid prednisolone, because we know that the sort of systemic side effects and bone loss is significant with corticosteroids, and that's a major contributing factor to bone loss in these patients. There is increasing use probably of budesonide, which doesn't carry these systemic side effects and isn't associated with the bone loss. And we need to be really working towards maintenance of disease remission. And again, it's about keeping the inflammation quiet, as we know that that plays a significant role in bone loss. So we've mentioned already that nutrition is key. Well, adequate intake of calcium is absolutely critical in achieving optimal bone mass. There's probably deficiency through a couple of methods in inflammatory bowel disease, both reduced intake. We've heard mentioned already that patients that are suffering with abdominal pain often restrict their general input of food, and Their nutritional status can be poor, so there's reduced intake, but there's also reduced intestinal absorption reported in Crohn's disease. So we really need to be looking at patients having a good dietary requirement and whether or not they should be having supplementation. It's suggested that around 1,000 milligrams daily is the dietary requirement of calcium, increased to 12 to 1,500 milligrams in postmenopausal women. And it says here elderly men, but it really is talking about patients sort of from their 50s and above need a higher calcium intake because of the increased risk of osteoporosis as we age. Calcium supplements are a little bit controversial because there is some suggestion that if they're used when there isn't a deficiency or a lack in the diet, then they can increase cardiovascular risk, and they shouldn't therefore be used without vitamin D in association. But I think most that we prescribe would be a combined preparation anyway. Again, coming on to sort of vitamin D, deficiency is much more common in inflammatory bowel disease patients. So more than half of patients with Crohn's and colitis have a vitamin D deficiency, and this is multifactorial. So again, reduced dietary intake, reduced intestinal absorption, but also disrupted enterohepatic circulation. We should be looking for that deficiency, and when we find it, we should be treating it. And I think it's important to remember that it can occur even with normal bone profiles. And so it perhaps depends locally what testing is available, but consider testing for vitamin D levels if it's available, or parathyroid hormone if not. And it's really important to treat it with full treatment doses and then maintain them on vitamin D thereafter. So as I've mentioned already about supplements, calcium and vitamin D supplements, whilst patients are on steroids, are probably recommended, and we'll talk about this in a moment, but long-term use beyond this, unless patients have a high risk, is not indicated unless they've got a low dietary calcium. It can be quite difficult when you talk to patients about how much calcium they take, whether or not they meet the 1,000 milligrams a day. And there's an online calcium calculator which is linked into this slide, which I tend to suggest to patients that they look at themselves and sort of input their diet into it and work it out from there. So let's go on to talk about bone protection and steroid use. So I've obviously already mentioned that if possible, we avoid using steroids, but unfortunately there's going to be patients that are going to require this to control flares and get their disease into remission in the first place. What we do know is that bone mineral density loss and increased fracture risk occur with oral corticosteroids, and the most significant effect on that bone loss is within the first 3 to 6 months of treatment. So really we need to be thinking about it early on in our introduction of steroids. Generally, the recommendation is that we use bisphosphonates when commencing steroids in anyone over the age of 65 or if they've had a previous fragility fracture. In those that are younger, or in patients that are requiring steroids for a longer longer period of time, then we can carry out a risk assessment incorporating age. Now, this would probably recommend that you use a FRAX tool, which is an online interactive tool that uses 10 different risk factors to calculate a patient's 10-year risk of a significant osteoporotic fracture. And then in these patients that are identified to be higher risk, then we should go on to do bone densitometry. And we should consider bisphosphonate therapy for the duration of steroid treatment if their T-score is less than -1.5. I think the only thing to say about bone densitometry is that the weight for these investigations may be significant. I certainly know in our area it is. So I think we probably need to be considerate into introducing bisphosphonates in those that we identify as high risk. So a FRAX score of greater than 20%, or if we know that they're going to be using a longer course of steroids. And the other thing is that the FRAX only considers a sort of low dose prednisolone dose it assumes of 2.5 to 7.5 milligrams daily. So those on higher doses, it may be underestimating the risk. So just some considerations when using the FRAX and when we talk about bone densitometry, bearing in mind that we know that effect of bone loss happens in the early stages of treatment. Waiting for a DEXA might not be appropriate. We've talked already about supplements and their use. I think that calcium and vitamin D use during the time of prescribing steroids, there isn't a lot of evidence or strong evidence to say that it's beneficial, but there also isn't evidence that it's harmful while they're on steroids. And some studies have shown a small beneficial effect. So I think it's completely reasonable to be using a supplement such as Adcal or Calcituse and so forth while they're on steroids. There isn't any justification for us to be doing routine DEXA scanning in all inflammatory bowel disease patients. However, I've already mentioned that a significant proportion of patients are affected, so we do need to be looking for the patients that are at risk and considering who we test. When we look at those that are most at risk, we're thinking about the patients we've already mentioned, those that are on steroids. So anyone that's on 7.5 milligrams of prednisolone a day. Previously it was for more than 6 months, but the recommendation really recently is anyone that's been using steroids for more than 3 months is deemed at higher risk and should be undergoing a DEXA scan. Anyone under the age of 65 that's at higher risk for other reasons, so low BMI, and consider those with prolonged, active, uncontrolled disease. We've talked about the fact that inflammation carries a risk of bone loss. So I think, there aren't hard and fast rules about who we should be doing a DEXA on, but we need to be thinking about those that have got chronic uncontrolled disease being at higher risk. As far as I've mentioned already, at those with persistent, continuing, very active disease, and again, long disease duration, because the bone mineral density over time is likely to have been affected. But also think about their other risk factors. So the other risk, the non-IBD risk factors that we've already mentioned, smoking, low body weight, and so forth. I guess low body weight perhaps, more relevant in the IBD patients, and again, poor nutrition. So it really is a matter of looking at all their risk factors and trying to bring them together to decide who needs a DEXA scan. When it comes on to the treatment of osteoporosis, essentially we should be offering treatment with bisphosphonates to those with the reduced bone mineral density and those that are at risk with risk factors for fracture. Bisphosphonates, so alendronate, alendronic acid, and risedronate, can be given orally, either on a daily or weekly basis. And if they're not tolerated, patients can be referred to be considered for intravenous therapy. Patients who are pregnant can take calcium and vitamin D supplements safely, but other osteoporosis treatment is not proven to be safe in pregnancy. Studies do show that adequate absorption of oral bisphosphonates occurs in patients with inflammatory bowel disease, so there's evidence that there is an increase in bone mineral density in patients taking oral bisphosphonates with active inflammatory bowel disease, so we know that they are being absorbed, and there are studies out there that do show reductions in vertebral fracture and actually non-vertebral fracture in patients with osteoporosis and inflammatory bowel disease. I would consider, if they're not tolerated for oral bisphosphonates, these are the patients that need to be referred to your local bone clinic for IV zoledronate or teriparatide. So with regards to the ongoing management, an area that perhaps we're all aware of, oral bisphosphonates, we know they're safe, we know they're effective on the whole. They do carry a significant side effect, and whilst it's rare, it seems to be more common in patients that are on them for a long period of time. So the osteonecrosis of the jaw and these atypical fractures that we've seen associated with bisphosphonate use tend to occur in patients that have been on them for longer than 5 years. So I think we need to consider stopping the oral bisphosphonates after 5 years of use, unless the patient is greater than 70 years of age or has had a previous, and actually I think in some guidelines that's considered 65 years of age, or if they've had a previous hip or vertebral fracture, if they sustain a fracture during treatment, or if they're continuing on a significant dose of steroids. If we do discontinue treatment, remember to reassess the fracture risk 18 months to 3 years down the line, or if they sustain a knee fracture at any point. The latest BSG guidelines publish a nice sort of summary slide on osteoporosis management, and hopefully covers everything that we've talked about. So I won't go through it in detail, but it's really useful to refer back to it. I think in summary, I would just say that, it's really important to try and identify those patients at risk. If you feel they've got a lot of risk, it's important to get them an objective measurement of their bone mineral density with a DEXA scan. And if there's any concerns, I think liaising with your local bone clinic is definitely worth doing. So thank you very much for listening to this webinar. Remember that there's a whole host of resources available on the IBD toolkit at rcgp.org.uk/IBD.